Hello, everybody. I'm Rob Wallace here in St. Paul, Minnesota. I'm an evolutionary epidemiologist with the People's CDC here with an update on the COVID-19 pandemic. This week, we'll cover the state of global COVID and the state of U.S. COVID. We'll also cover how the CDC is framing its superspreader event in Atlanta and how the Biden administration is helping claw back COVID funding. And we'll explore what those two efforts say about how far the political class is prepared to go to allow long COVID to spread through the American people. For global COVID, in the top graph, our world in data using WHO data reports us down to only 180,000 confirmed global cases the week ending May 31st. The bottom graph shows us as only 931 confirmed deaths. Are such data real? Just a month ago, before the end of the public health emergency, the US alone was reporting over 1,000 deaths. Now, in the interest of trying to get you some sense of the nature of the pandemic, the People's CDC has been cobbling together these kinds of data across different variables from the start of our broadcast. But as the People's CDC's own Howard Waitskin, a medical doctor and sociologist, remarks, there are plenty of reasons why these data are problematic, even before the end of the emergency. In previous COVID This Week broadcasts, we talked about the variation in the definitions of what comprises a COVID case, the failure to include measures of variability and the reliability for key markers like cases and deaths, and the need for more studies based on random sampling. Waitskin writes, quote, based on these considerations and others, it is clear that some data about this pandemic and other epidemics manifest much higher quality than other data, but assessments of the differing quality of data appear rarely in reporting of scientific publications or the popular media. The People's CDC will try to rate the quality of data that we report and will give a rationale for these ratings, end quote. At this juncture, and not without a touch of irony, our rating will not be based on analyzing statistical power, but how well it appears the results presented meet our notions of case reporting, measures of dispersion, and the nature of the statistical population the measure is drawn from. So we'll use a traffic signal coding to tell you what we think of the validity of each measure as well as its soundness. By validity, we ask, are the data sufficient for capturing the measure presented? By soundness, we ask, do the data capture the broader reality other data have also already converged upon? That is, do they converge on a greater reality as we presently understand it? In the weeks ahead, we'll explore how our initial coding here lines up with the definitions of quality data published by the McMaster and Cochrane efforts, considered to be gold standard in the field. So this is very much a work in progress. So we see here that the near linear decline in caseloads and deaths unlikely capture the state of global COVID out there, making validity red. But it may still mark the seasonal contraction in COVID, making the measure's soundness at best yellow. Now, this case might not sound right. How could an invalid measure capture reality? In this case, by a combo of chance convergence upon likely seasonality and a mix of some countries still reporting in, while others aren't. Indeed, countries across the world are reducing, if not abandoning, surveillance. We see from such a snippet of the list of cases per country that Afghanistan is reporting as close to 1,000 cases the week ending May 31st, while Argentina, slightly larger in population, is reporting 0, like not a single case of COVID in the entirety of the country for the week, as are many other countries down this list, A to Z. We see from the Economist data set of the 7-day average of excess deaths per 100,000, a flattening out of excess deaths toward pre-pandemic levels. No countries reporting June 7th showed excess deaths beyond a half a person per 100,000 population. That indeed converges upon a lesser COVID pandemic. But as we reported last episode, health ministries, including here the UK Office of National Statistics, among others, are starting to cheat on this measure by changing the baseline from which to compare present excess deaths. Instead of comparing deaths now to deaths before the pandemic, ministries are comparing deaths now to a running average of 5 previous years, which in this case includes 2 years of the pandemic. The death difference melts away when you compare the present pandemic and the early pandemic. It's why we now mark what should be a rock-solid measure in the face of an abandonment of COVID surveillance, only yellow in validity and in soundness. in summing up the reality of excess deaths out there. Using WHO data, Our World in Data shows weekly hotspots as of May 31st. Of the countries reporting in, parts of Europe are reporting the highest figures. However, no more than 500 COVID cases per million population. Our World in Data warns, however, that confirmed cases are lower than the true number of infections due to limited testing. Indeed, along with the countries reporting no data in the hatch marks, many in the yellow, including the US and Russia, are, as we remarked on, reporting no cases, as in zero, which we know isn't true. At the same time, we see from these percent changes in caseloads the past couple of weeks, rebounds there in the warm colors are still scattered across the globe, particularly Haiti, Spain, Togo, Libya, Botswana, Bangladesh, China, and Cambodia. So even off a lower floor, rebounds are still in play. Such demonstrated rebounds make set validity and soundness both at yellow. Such slight increases in large populations, as in China, can translate into huge numbers, including, in this round, a projected 65 million new cases per week by the end of the month. Like the US, NBC reports, China stopped providing weekly case updates this month, making it difficult to know the true extent of the current outbreak, end quote. And at a time when the vaccine strategy many governments say they were pursuing instead of non-pharmaceutical interventions has all but faltered. Much of the world is at best vaccinated for variants no longer circulating. We see uneven campaigns in booster vaccination across the world. On the one hand, Peru, Uruguay, Argentina, Cuba, Belgium, Sweden, and Japan showed top-tier booster campaigns, with 70 or more booster shots administered per 100 population. In contrast, we see near nothing in Russia, India, and Pakistan, those even reporting in from Africa, as well as mediocre campaigns in Brazil, Spain, and Eastern Europe. This map hasn't changed much, although fewer countries are reporting in, indicating these campaigns have largely ground to a halt. Indeed, the CDC reports the US stuck at 17% of its eligible population 5 years and older with an updated booster dose. And we can see from this time series a combination of some countries no longer reporting in, but almost a universal tailing off of new vaccinations since spring 2022. Meanwhile, the mediocre vaccination campaigns, hand in hand with the rollback in the non-pharmaceutical campaigns that successful vaccination depends on, have been taking place alongside the continuing emergence of multiple Omicron subvariants, now circulating across large expanses of the world. XBB 1.5 in blue is suddenly getting replaced by other XBBs, including in this batch, every country but Australia. While the genetic sequences identified here are a small, convenient sample of what national labs sequence, the aim here is to get a rough handle on the distribution of some of the possible variants circulating. So the sequencing itself is unlikely to misidentify the variants. For our purposes, making validity green at both the individual and population levels, even if soundness in yellow, the reality out there is only somewhat captured. For other countries, as of June 5th, we're drawing from covariance.org. We see a wider mix in China, BA5, BA2.75, XBB, XBB 1.5, and XBB 1.16. Malaysia is reporting in that XBB, along with XBB 1.5 and XBB 1.16. Singapore is hosting BA 2.75, XBB, XBB 1.5, XBB 1.6, and a new recombinant. Finally, here, Sweden is reporting the same, except no recombinant. Joining what Rajanarayanan shows is the world diversity of sequences the past 20 days as of June 4th. XBB 1.5 is still hanging on, leading the way in light blue, in part due to the sampling bias toward high-income countries, but we see many subvariants and sublineages in play, including many XBBs like XBB 1.9.1 in forest green, and XBB 1.16 in purple, as well as FL2 in salmon and EG1 in red, among others. That the world is still hosting and sampling such a large zoo of variants makes this map green in both validity and soundness, even if not every single lineage has been sequenced. In the face of the declines in country reports, we could use the molecular clock ticking off mutations in a regular fashion across SARS-2 lineages and the accumulation and variation month to month to estimate the global total infections in the stead of these deteriorating case load reports. Now, that's something the People's CDC will look into. That is, the People CDC would like to look into the kind of phylogenetics this French team just published for the world, Europe, and France, using 2020 SARS-2 genetic sequences, estimating here for the world the number of cases over time and migration events place to place. Now, tracking cases is important. We need to track the number of cases to track the number of long COVID cases. Just to remind us of the scope of the damage long COVID induces, here's a figure showing some of the classes of symptoms long COVID patients reported in a meta-analysis of 18,000 studies, from which 15 met selection criteria. So, cognition problems, affective disorders, general fatigue, heart and pulmonary damage, digestive problems, skin and joint problems, and so forth. And of course, as a new South African study shows, these symptoms speak to each other in combinations of interactions, which we can trace by biological mechanism, here autoimmunity's impact across symptom sets, or by symptom. Unsurprising, given SARS-2's wide tropism, attacking ACE2 cells across the body, but which makes each patient's particular long COVID difficult to diagnose and treat. Long COVID is proving a nasty version of choose your own adventure. We'll look at new studies on the impacts on two organ systems. A new Dutch survey found increasing memory and concentration problems among adults since the start of the COVID pandemic. These aren't so much 75-year-olds, they're 25 to 44-year-olds. The Dutch National Institute for Public Health and the Environment and the Netherlands Institute for Healthcare Research found a 31% increase in primary care visits by adults ages 25 to 44 for these problems, and a 40% jump in such visits for 45 to 74-year-olds. There was an increase of 18% in 75 and older. A previous Dutch study showed 15% of respondents had ongoing brain fog, which consists of a mixture of memory and concentration problems. The reported symptoms, including brain fog, are 1.5 times more common among those who had tested positive for COVID-19 than among those who have had other non-COVID respiratory infections, including influenza. We've previously reported the proximal mechanisms for such cognitive and affective disorders, including brain cell death, hypometabolism, and deoxygenation. A University of South Carolina team just published a study showing its experimental group of 28 patients previously mildly infected with COVID had significantly lower whole brain and white matter cerebral blood flow than its control group matched for age, sex, hypertension, diabetes, smoking, and alcohol use. The white numbers here indicate axial slice location. The color bar represents the z-scores for the comparison with only statistically significant regions marked. The team derived a diagnostic model for COVID severity based on a combo of more and less blood flow, finding lesser flow in, among other areas, the left superior temporal gyrus, associated with language processing, auditory short-term memory, and both perception and production of speech, and the left superior parietal gyrus, associated with the manipulation of information in working memory. The middle front gyrus impacts working memory and attention control. There are 7 other parts of the brain so affected. A new Case Western NIH study showed COVID-19 significantly associated with Alzheimer's disease 360 days post-infection across age, sex, and race, although especially in older patients and women, as you can see from the hazard ratios on the right. The study is only a starting off point and requires follow-up, including the retrospective nature of the study, the difficulty in diagnosing Alzheimer's, and the need for a mechanistic explanation of how SARS-2 helps produce Alzheimer's. As we saw in the big picture diagram we began with, the brain isn't the only target. A University of Leicester team published a review on long COVID's pulmonary impacts, the lungs, including pulmonary fibrosis, thromboembolic disease, or blood clotting. Extrapulmonary complications like frailty and reduced exercise tolerance we reviewed previously in COVID this week may contribute to breathlessness in long COVID. This diagram shows that post-COVID pulmonary damage of interstitial lung disease, ILD, on the right shares some of the same mechanistic pathways as idiopathic pulmonary fibrosis, IPF, on the left, with some shared risk factors in the green middle box at the top, including male sex, older age, hypertension, diabetes, and some genes. There's a lot of IPF out there in the world, so the authors are warning of the population prevalence of the damage that long COVID ILD is likely to be causing. Now, it's remarkable that the people waving COVID off as so much 2021 are also walking around as if this were still 2019. And one needs to ask, are these the types of brain and lung parts that we're prepared to gamble with? Turning to the US. The Walgreens COVID-19 Index of National Test Positivity covers both rapid tests and PCR. As of June 4th, we see positivity up a smidge under a quarter of all tests, although the number of tests conducted is in precipitous decline. The CDC reports the latest round of excess deaths associated with COVID during the pandemic in blue and those associated with non-COVID causes in yellow, above the expected average deaths of 6 years before the pandemic, as shown in orange. The last excess death count above the threshold in the red pluses there for both COVID and non-COVID causes is January 21st. With the end of the declared emergency, counties and states are no longer obligated to report in caseloads and deaths. A decline in reporting that was already in motion, hand in glove with, as reported, decreased laboratory testing, increased home testing, changes in reporting practices, and asymptomatic infections, end quote. Instead, the CDC replaces the almost always all-green map of community levels with another all-green map of percentage of provisional deaths due to COVID for the week ending June 1st. We no longer have access to the raw numbers. Epidemiologist Isaac Michaels is continuing to map the community transmission map CDC abandoned, at least for his home state, New York. For the week ending June 7th, the state registered 23 confirmed COVID deaths the past week, 757 COVID hospital admissions, and a 4.5% positivity rate. We see 19 counties supporting high or substantial transmission based on test positivities and caseloads, up 8 counties from last week. Detecting SARS-2 in sewage wastewater remains in place. We see the levels of SARS-2 virus detected in the wastewater, in some ways a leading indicator of the pandemic for May 15th through the 29th. In the oranges and reds, we see plants at 60% or more of all the samples in SARS-2 detected taken nationally since December 2021. In 2 plants in Arizona, a few plants in Ohio, a couple in Louisiana, single plants in Michigan, Missouri, Arkansas, and a handful in New York State and elsewhere in the Northeast. Finally, a few across Virginia and the Carolinas. But much of the country is under 20% in the distribution of samples reporting back to December 2021. On the other hand, the more acute measure of changes in sewage loads over the past 15 days shows some areas heating up more than others. Here and there in the Pacific Northwest, especially Oregon, Colorado, throughout the industrial Midwest, Louisiana, much more to the south than last we checked, and now suddenly downstate New York, including New York City and southern Maine. These could be threatening spikes or just increases off a lowering floor. Again, no raw numbers on hospitalization, but the changes in percent hospitalized for COVID the past week by county, with bright oranges showing substantial increases of 20% or more. Now, is it 20% increase from a small set of cases last week or from a large batch? That's now unclear. The outbreak stateside continues to evolve, with here the continued dominance of XBB 1.5, but also now the emergence in the blues at the bottom of XBBs 1.16, 1.51, and 1.91, and the new arrival XBB 2.3 and 1.16.1 in the pinks. Here's a 21-day trend of all the genetic sequences of detected sublineages in the US as of June 7th, including their geographic origins. In what appears fewer samples reported in, XBB 1.5 in blue is still ahead in states across the country, but beginning to give way to other XBBs. Big picture, there are all sorts of other subvariants and sublineages circulating in such a way as to offer possible candidates for the next dominant variant or to contribute to the next recombinant that accelerates beyond both vaccine and population immunity. What we're getting at here is that the pandemic is not over. We finished this episode with a note on the messages 2 administration responses this month imply as to its attitude about the COVID-19 epidemic upon ending the public health emergency last month. The Washington Post reports that the COVID superspreader event at the CDC-sponsored conference at an Atlanta hotel late April increased to 181 cases. That's 13% of those surveyed infected at a single event. Never mind the taxi drivers, airplane passengers, waiters, hotel staff, friends, or family also infected. Where 70% polled went without masks, 52% had no previous COVID infection, and over 99% were previously vaccinated. Now, one upshot is that packing in nearly 2,000 largely unmasked people can produce a super spreader event, even with nearly total vaccination. The vaccines do not offer sterilizing immunity. The other upshot isn't what CDC thinks it is. In a press release, the CDC noted no one surveyed was hospitalized. Yes, that might mean vaccines still help with morbidity during acute infection, but the position CDC is explicitly staking is that CDC is no longer harmful. And going unmasked is perfectly reasonable. We did nothing wrong. Not a word about the role reinfection plays in the increasing likelihood of long COVID, even for the vaccinated. The administration, meanwhile, continues to push back the commons post-emergency. It helped use the self-imposed crisis of a debt ceiling no other nation follows to cut social spending by $136 billion through fiscal year 2025. In addition, work requirements were added to food stamps, student loan payments were restarted, another natural gas pipeline was green-lighted, health spending was frozen during a period of unprecedented inflation, and $27 billion in COVID spending was clawed back, including $10 billion from the Public Health and Social Services Emergency Fund and $1.5 billion from the CDC, although leaving in some money for developing next-generation vaccines and researching long COVID. With only the $800 billion in defense spending atop paying for the war in Ukraine, the exception, those were left alone, with more House Democrats voting for the deal than Republicans. Yes, in part because the Republicans wanted to decimate social services even more, but this is not a victory for the Democratic Party, and certainly not for the American people. According to the Center on Budget and Policy Priorities, the agreement will, quote, increase hunger and poverty among older poor people. As commentator Jeffrey St. Clair puts it, quote, Biden claims he compromised on the budget and not the debt ceiling. Of course, that's the point. The debt ceiling only exists to provide neoliberal politicians like Biden an excuse for imposing austerity on social environmental programs while funding an ever-expanding defense budget, end quote. Making passing reference to the People's CDC, Matt Mazewski reviews the start of what will be significant damage to both national health and well-being, entirely the result of the political class's concerted decision-making. The administration is right, Mazewski describes it. Republican Limit Save Grow Act plan is both morally objectionable and economically self-defeating. Everyone deserves to have health insurance regardless of their station in life, and people who cannot pay for medical care will be less productive workers too. But it takes real chutzpah to attack your opponents for trying to kick millions of people off Medicaid when your own policies are about to result in the very same outcome. The Biden administration is currently on track to preside over what will likely be the largest mass disenrollment of Medicaid recipients in the history of the program. What's even worse is the fact that this disaster is entirely avoidable. It is happening only because of the president's failure to fight for the continuation of measures implemented as part of the federal government's response to COVID-19. The end of the year budget deal signed into law by President Biden in late December of last year, Mazewski continues, allowed states to bring back annual Medicaid eligibility checks starting on March 31st, even while the public health emergency was still in effect, and a number of states have already done so. The Kaiser Family Foundation estimates that between 5.3 million and 14.2 million people stand to lose Medicaid coverage during the unwinding period over the next 12 months. Estimates from the Department of Health and Human Services suggest the number could be even higher. On top of that, Mazewski continues, HHS has projected that around 6.8 million of those disenrolled might still be eligible, but will nevertheless go without coverage until their eligibility is verified. Given the overwhelming administrative burden this is likely to impose on state bureaucracies, even those who are entitled to coverage may have difficulty getting it back once they've lost it. Biden and Democrats in Congress could have fought to prevent the repeal of continuous eligibility, but they didn't, end quote. The message couldn't be clearer. Not only is COVID-19 treated as too difficult to solve as an epidemiological problem, once the professional managerial class appeared largely in the clear, but from these long COVID interactions, too difficult and expensive to treat. Not because there isn't money, there is, but too expensive beyond spending for rich people's tax cuts and nearly $1 trillion on the military. So in the short term, either you'll pay out of savings most Americans don't have, or you'll be gaslighted out of the hospital with long COVID beyond medicine's present capacity, because the political class won't be paying for this. Even as CDC's own research shows, as Eleanor Bader reports here, quote, that 1 in 5 adults between the ages of age 18 and 65 and 1 in 4 adults over the age of 65 will develop lasting health problems from COVID. Nearly half, 44%, will be unable to work because of them, end quote, unless we fight back, as in this protest in Los Angeles this past week, demanding full COVID care coverage and keeping mask mandates in healthcare settings. This month, the People's CDC pushed for people to submit comments on the federal register to Centers for Medicare and Medicaid, or CMS, to tell them to dictate hospitals keep mask mandates in place and prevent hospital-acquired COVID. We'll have the link for you in the video description so that you may contribute your own comments. And that's COVID This Week. You can find all our episodes on the People's CDC YouTube channel. You can learn more about the People's CDC and read this week's COVID weather report at our website, peoplescdc.org.